Good afternoon, everyone, and welcome to our board development webinar titled Know Your Numbers, What Gets Measured Gets Done, and the part that they play in your work on health and wellbeing. I'm Louise Pratt, Project Lead for the Health and Wellbeing Project at NHS England and NHS Improvement. And we've got two fabulous speakers for you today in support of the Improving Health and Wellbeing programme. We've got Dr. Steve Boorman and Dr. Christian van Stolk speaking with you today. I'd just like to run through some housekeeping before we get started on our session. So, on our agenda today, we do have some time built in at the end to ask questions, but through this Workcast platform, you'll be able to submit questions via text, and I'll be keeping an eye on those on your behalf, and generally, I'll be saving most of those till the end, but if there's a question that comes through that's particularly relevant to a particular statement that one of our speakers has said, then I will interrupt them on your behalf and ask that question. So please do submit questions as you think of them. I'll be keeping an eye on those. And if we're not able to answer all the questions in this webinar, then we'll attempt to follow those up afterwards and make those available to you. If your sound drops out, can I ask that you try refreshing your browser window or switching web browsers? Sometimes it works better on alternative platforms. And this webinar is going to be available to you to view again on the same link that you've accessed it within 48 hours. And actually, we do intend to publish this on our programme website. So watch this space. There will be a link coming round. And at the end of the session, we very much appreciate your feedback. All feedback is gratefully received, and it helps us to learn and improve on these webinars and make sure that we're covering the things that are most useful to you. So, that being said, without further ado, I'm going to hand over to Dr. Steve Boorman.
So, thank you, Louise. Could we go on to the next slide? That's great. Thank you for the opportunity to come and work with you today and to talk to a subject which, I guess from experience, I know is really important to driving successful health and wellbeing programs through. And it's also a great pleasure to work today with an old friend, Chris van Stolk. Chris and I have worked together on very many occasions, and I know that basically he will talk about Britain's Healthiest Company, which is something that I've also been involved in and feel quite passionately about. It's important to say that I'll talk a little bit about the review that I was involved with in the NHS back in 2009, looking at the role that staff health and wellbeing played in delivering good quality healthcare, and Chris's team were absolutely crucial to that, and were crucial in helping me understand how important the numbers actually are in making the case. So, I thought it might help if I shared with you a little bit of the context and the learning journey that I personally have been on. And I've been in occupational health now for over 30 years. I've had multiple roles, but I spent 21 years in various roles in Royal Mail. I guess for the first half of my career in Royal Mail, the type of occupational health that I was involved with was pretty traditional. It was helping people back to work after illness. It was helping people either find alternative employment if they couldn't cope with the jobs that they were doing, or it was helping people to leave the organisation if indeed that's what their health required. And that's reactive occupational health. And we did quite a lot of health promotion in Royal Mail, but we did it really in a fairly ad hoc manner. And in terms of a history lesson, in the early 2000s, Royal Mail started to run into problems. And you might think, well, what's Royal Mail's problems got to do with the NHS? But actually, they're remarkably similar types of organisation. They're both very large organisations. They're both very complex organisations. And they're both organisations that rely very heavily on people in order to actually deliver the service that the public trust and expect from them. They're also both services in which the expectation is really very high and the consequences of failure can be great. But at the beginning of the 2000s, Royal Mail was in serious trouble. It was in serious financial trouble. It was missing all of its regulatory targets. It had low morale among its staff. It had high rates of turnover. And we found that many of the people that we were recruiting into the organisation were not staying very long in the organisation. And not surprisingly, because that was about the time that I became a direct report to board in Royal Mail, I was summoned to quite an early board meeting, and I went in very carefully knowing my numbers in relation to my departmental performance and expecting to be challenged on how many nurses and doctors and physios that I was actually employing in the service that I was running. But actually I was quite surprised to find that a new leadership team, and particularly the chairman and the chief executive, instead asked me the question, what's the impact of sickness absence on our organisation at the moment? And I found myself blushing a bit because I had a sort of vague figure in my mind, but I didn't actually have any data in my hand that enabled me to respond objectively to that question. So I did what any good director would do, and I played for time. And I offered to go back in a few weeks' time with some numbers. And we then found how difficult it was to actually get good numbers in this space. Because although Royal Mail had a common HR system, it actually had 33 different versions of that HR system, and in different parts of the organisation they were using that HR system in subtly different ways. So they were recording absence against different categories, and they were recording absence using different denominators and different numerators. You might say that never happens in the NHS, but I'm afraid my experience of some of the ways in which ESR is being used actually reinforced that actually there's quite a lot of commonality there. I went back into bat with a figure for the impact and cost of sickness absence, which was not surprisingly to an organisation at that time hundreds of millions of pounds. But embarrassingly, the bright graduate that had helped me find the numbers knocked on my office door the next morning and said to me, I'm afraid there's a problem with the numbers I gave you. And what we found was that actually, even though we were recording numbers in what we thought was a system measuring absence, it was actually a system linked to payroll. And actually, once people started to become not fully paid, they became less than half absent, or not absent at all in the system. And so my numbers were nearly a third out. So if we now move on to my experience in 2009, when I was invited by the Health Secretary to look at the impact of NHS staff health has on patient outcomes, regulatory performance, and organisational efficiency. I actually found that actually the way in which the NHS is structured was a remarkably similar system to the Royal Mail system, with some central direction and control, but actually considerable local differences in the way in which things actually happen are implemented. And it wasn't actually very difficult to find the data with Chris's team and the other research teams that actually showed that staff health and wellbeing was important and did have a significant impact. What was much harder to do was to actually quantify exactly what that impact actually was. Because although we published a figure for the total cost of sickness absence, which we estimated at that time, 10 years ago, as £1.5 billion, actually there are an awful lot of other things that actually don't get recorded and considered in the same discussions when the board are concerned about sickness absence. So there are things like the agency costs, there are things like the impacts on retention, there are things like how easy it is to attract and recruit people into the organisation, and there are the impacts on care performance, particularly in terms of things like mistakes and litigation and safety at the end of the day. And it's only when you start to put all of those costs and that data together that you start to understand that there is an absolutely barn door case for actually supporting the health of your staff. And it's an investment, not a cost. The other thing that I found in the 2009 review, and I have no reason to suspect that it's different today, is that this is often thought of as being an HR issue. It's something that's left to the HR or the people director or the people person in the organisation. And our turning point in Royal Mail came when we actually changed it to become an operational issue. It was part of the thing that underpinned us turning the service round and actually getting the performance that the service actually needed to. And so it's hugely important to have board visibility and accountability, and unless you can present numbers, you can't get that engagement and that commitment. So I would ask any organisation that wants to take this seriously, can you answer some very simple questions? And those questions aren't about rates and what's in ESR, they're actually about the impact of sickness on the organisation on a day-to-day basis, and how much is it operationally costing the trust in terms of the impact that it's actually providing. And back in 2009, my team set a challenge figure suggesting that actually absence could be improved by a third in the NHS. I still believe that figure is in fact an underestimate, and I've seen NHS organisations that have actually focused on this area and successfully implemented programmes actually achieve savings that have actually been significantly more than that. And I know that's a challenge across the whole system. But earlier this week, I was at a conference in which North Bristol Trust shared their results between 2018 and 2019. And in just 1 year, they changed their staff engagement scores in key areas by over 5%. They gained a significant improvement in their CQC rating, achieving a good performance and an outstanding performance for quality of care. And they documented 4,000 reduced lost days saving over the years, resulting in a £300,000 saving in direct salary costs. And actually, they had calculated the impact meant that they had 400 additional staff working each calendar month. And that's the sort of numbers that actually make a difference in terms of getting understanding and commitment. So I think the other thing, in addition to the key questions, is also not being confident simply because you have a policy or a process, that that's actually what's taking place on the ground. And quite often we don't put numbers and measurement around some of the simple processes that actually make a huge difference to how people feel in an organisation. So again, winding back to 2009, we looked at some very simple things which were actually already NHS policy: return to work interviews, regular appraisals, regular contact with a line manager. But when you ask staff in confidence, did that actually happen? And in organisations that were reasonably confident that these things were deployed, the actual rates were down around 50% or so, because people were too busy, or they didn't prioritise them, or they didn't feel that they were important. And again, I would say that if you don't measure these things, you can't be absolutely confident that they're actually happening. And that's not because managers in the NHS want to be bad managers, but it's sometimes because they don't know that they need to do something, and that's what I would describe as being unconsciously incompetent. They don't know where the policy is, or they don't know what they should be doing at this time. And sometimes actually it's because actually they do struggle with some of the people skills, just as in Royal Mail. We have a system that will sometimes promote managers on the grounds of their seniority or their long service or their technical experience, rather than necessarily because they actually understand some of the people things that are needed to underpin good staff health and well-being. And in this area, this is an area where actually doing the wrong thing can positively disengage people. People feel their manager doesn't care. And that may be an act of omission rather than an act of commission, but people just don't feel that things have been recognised. So 10 years on, we still have some challenges. And I think actually what's been very useful for me over the last few years is the work that I've been involved with NHS England, with NHS Improvement and NHS Employers, in terms of starting to put together the materials that support the staff health and wellbeing framework that you've created. And this is an excellent resource that helps people to understand the levers and to understand the measures that are actually important in terms of securing the commitment that is needed if we're going to make this work. One of the key findings working with the pilot trust that started to look at what should be in a good framework was actually understanding that this isn't about putting on token Zumba classes or introducing lettuce leaves in the canteen, although they may be part of an overall programme. It's really important to get the basics right first. One of the things that drives getting the basics right is having data and information that enables you to actually demonstrate the issues. So in order to get the framework has underpinning it some key enablers, which are the three basics that are needed that you then build good working workplace wellbeing programs on. And those three key enablers are about getting leadership and management commitment. They're about having good data and being able to communicate it clearly. And they're about securing a healthy working environment. And the framework actually breaks out. Yes. And the framework actually breaks out and shows very clearly that actually when it comes to numbers, hard numbers and soft numbers are important. So there may be situations in which at things like attendance rates, attraction rates, retention rates actually are there, but there are also soft numbers in terms of how people feel and the issues that actually the people are raising that are important to capture in this. And clearly once you put programs in place, one of the things that often gets missed is actually saying, well, what will good look like? What will success look like? And again, numbers are important to that. So the framework recommends some proposed measures that organisations can consider to actually measure their progress. But what's really important is that those measures are impactful for you and you at a local level. And so I would support fully the use of the framework, which again has got many, many very good examples of how to know your numbers and understand where you are, to understand how well your organisation is performing. But I think the last point that I would make before I hand over to somebody who really knows their numbers is that actually data can actually be quite challenging in terms of the way in which it's expressed. So we tend to talk about rates data or percentage data, and that's not always meaningful when it comes to actually measuring impact. So in Royal Mail, it was when we were able to go back into the board and say the impact of the programmes that we're running are delivering 10,000 additional staff delivering mail each day. It was actually when we were able to go back in and say we used nearly half as many agency staff in the last week as we did previously. And that's not only saved us money, but it's increased the quality of the service that we're actually providing. And that's why I think it was so impressive to me earlier this week to hear North Bristol Trust talk in exactly that language and to be able to celebrate those numbers, which are truly important. And the last point on this slide, and before I hand over to Chris, I think it's hugely important to be able to measure the return on investment and express it in terms of the savings or the gains that have been made for every pound spent. My experience with the NHS is that it's quite a difficult environment to make the spend to save argument. But unless you start out with a programme being able to collect the information that enables you to demonstrate those savings, then actually the programmes won't be sustainable going forward. So I look forward to some challenging questions further down the line, but I'm now going to hand over to Chris.
Well, thank you very much, Steve, and it's a great pleasure to be here with you, and it's always great to follow you, Steve. And as you already mentioned, I spend my whole life creating an evidence base around health and well-being in the workplace, and also looking at data. And I was going to share a little bit of some of those insights with you today. The title of my slide deck, as you can see, is Understanding the Challenge in terms of health and well-being in the NHS workplace and getting beyond a tick box exercise. And I'll explain a little bit what I mean by that tick box exercise and especially in the NHS context. So before we get into the NHS, I want to kind of take a step back and think a little bit about an initiative that I've been involved in called Britain's Healthiest Workplace. And let me explain to you who are not familiar with Britain's Healthiest Workplace what it is. So on an annual basis, we do a competition, as you will be familiar with, sort of a best place to work, a good place to work competition, which is published in the Financial Times. We do that with an insurance company called Vitality Health. And basically what we're trying to get to is we're trying to understand what a good workplace looks like across a range of organizations. So it's voluntary participation. There's a range of surveys involved. So there's an employer survey where we ask typically an HR director in the participating organization what is going on in the workplace, the work environment, the context, etc. But then we also ask their employees about what is going on. And that's a minimum sample of employees who participate there. And we ask them about their backgrounds, we ask them about their health, we ask about well-being, we ask about the work environment, and we also ask them about the well-being offer, and so on. And not surprisingly, without giving too much away, there's a quite significant divergence between what organizations say that is happening, or at least the representative of the organization, says that's happening in in terms of health and well-being and what their employees experience. So that is the starting point. I should also mention there's about 400 organizations that have participated over the years, mainly large employers, and about 200,000 of their employees. So those are unique records. And within that survey, we've also had a wide range of NHS organizations participate, and I will come back to that in a second. So in terms of some of the key aspects to consider is what we can measure as part of this survey, and this is also getting into understanding your numbers, is what is happening in terms of productivity in the NHS, and of course, well, in organizations, I should say. I'll come to the NHS in a second. And of course, this gets to the point that Steve raised around the business case, and productivity loss is quite an important measure from that point of view, because of course it starts building that business case. And in our case, in Britain's Healthiest Workplace, the way that we identify productivity loss is the sum of what we call absenteeism and presenteeism. And of course, absenteeism is relatively straightforward to measure, because that is people not being at work due to ill health. Presenteeism, as you know, is a trickier concept to measure, because this is people being at work but suffering with ill health and therefore being less productive. And if you add those two together, you get to productivity loss. So if we look across the organizations that participate in Britain's Healthiest Workplace over the years, what we can see is that this productivity loss has worsened quite significantly between 2014 and 2018, the last time that we measured it. And I can already say in 2019 it's worsened slightly again, because we've just collected that data. And it's gone from 7.8% of working days lost, so that's basically of the total on average per worker, in terms of 7.8% of their working time being lost due to absenteeism, presenteeism, to 13.6% in 2018. So this is across the organizations that we survey. Now you might say, look, Chris, the sample of those organizations is not always the same year on year, and of course you would be right in saying that, but this gives an interesting indication year on year. I will not stand here and say that this sample is fully representative either, but it's just sort of taking the pulse of what is happening in Britain's workplaces. And what is then important to note is that the most significant part of this number, so the 13.6%, it has been the increase in presenteeism. And for instance, in 2018, that was 12.5% of working days lost, compared to 1.1% of sickness absence. And what we've seen is actually that sickness absence over the years has broadly stayed around that 1% mark, 1.2. Keep in mind, this is self-reported sickness absence, so as we collect it from employees. So you might experience that to be higher in your organizations on the basis of your administrative data. But what we see is, of course, that presenteeism is a much more significant issue as part of this productivity loss. And then the question is, what are the most significant drivers of this presenteeism? And not surprising, perhaps to you, we see factors such as poor mental health, lack of sleep, and financial concerns. The numbers are as follows, and this is taken across, again, the sample of all the organizations participating. So this is all sectors, all different types of employers across the UK. And here I put some numbers up that actually will tell you across our sample some of those risk factors that I've just mentioned. So the percentage of employees who sleep less than 7 hours a night is about 30%. And you might say, well, look, there's this Trumpian aspect of it, is that most successful people and high-powered individuals sleep a lot less, and therefore that's why they're successful. Well, you would be wrong. Because basically, sleeping fewer hours is associated with lower incomes. So typically those people on lower incomes sleep fewer hours. And it's also associated with other less desirable outcomes, such as higher rates of obesity and lower levels of cardiovascular health, for instance. So by all means, don't start sleeping less. So this is a fundamental issue. And of course, the NHS has a lot of shift workers as well. So keep in mind some of the dynamics that are playing out there. We also see an increase, and again, this is 2018 data. We've seen an increase with sleep quality. So it's not just sleep quantity, but it's also the quality of sleep. People getting up at night, maybe not having, this first uninterrupted sort of period of sleep, or long enough first interrupted period of sleep, which is actually crucial to your cognitive functioning. And keep in mind what would happen if you have groggy employees walking around the NHS and providing quality of care in quite complex situations. The percentage of employees who suffer from depression, we use a clinical scale here. It's about 5.6% across the sample, and again, as I mentioned, increasing. What is also an important factor is that we see quite a significant increase of the percentage of employees with a lot or a little financial concerns. So that is about 48% and increasing as well. So the sense is that employees are experiencing quite a significant amount of financial pressures. This is around the sort of 50% mark. Percentage of employees with at least one dimension of work-related stress, so this is measured by the Health and Safety Executive, is around 54%. And so the scale measures things such as relationships at work, time pressures, all of these different aspects. So at least 54% experience sort of stress at work. And then similar sort of measure, 2 or more dimensions is about 26.6%. So this gives you sort of an indication of the landscape. We're trying to move on. Hopefully we're all technically fine. Yes, absolutely. Great. There are quite significant differences also amongst the age groups. So you'll see that if you dig down in terms of productivity loss, there's a number of risk factors, and of course it's also important to understand whether these risk factors are even across the different groups that you might have in your workplace as well. So again, looking across our sample that we have using 2018 data, what you see is that the young have particular challenges in the workplace compared to some of the older workers. And this is also important to think about. So on all measures, more or less, and so this is productivity loss, so this is absenteeism and presenteeism, this is total well-being score as defined by the ONS, and high work engagement. What you see is that younger employees have worse outcomes across all of those measures. I could put depression there, I could put financial well-being there. It seems to be kind of a consistent picture. So this gets to my point, is that you also need to understand where those risk factors sit across the groups that you have in your workplace. So now as we move on, what do we know about the NHS organizations who participate in Britain's Wealthiest Workplace? So I mentioned that there were a range of NHS organizations that participate in the survey. We have about 30 organizations that over the years have participated, sometimes as part of a discrete initiative, sometimes on an ongoing basis. So this is quite interesting because we then can compare what's happening in those NHS organizations also to other organizations that are participating in Britain's Healthiest Workplace, but we can also start unpicking some things that we are noticing in an NHS organization. Now you might say, well, look, we don't need to participate in an initiative such as Britain's Healthiest Workplace because already we have the NHS staff survey and there's other data points. And of course you would be right partially, but of course this particular survey gives us slightly different and more detailed information as well in terms of the health and well-being of staff. So in terms of the NHS organizations that participate in Britain's Healthiest Workplace, there is a couple of questions that you need to answer in that sense. The first one is kind of, do you know your health challenges and so on in terms of the NHS population? And I guess this goes back to a point that Steve was making in terms of some of the simple questions that he was asking back in terms of knowing the answer to that. And in terms of the NHS, of all NHS employees participating in the survey, about 90% is part of the population with below average mental health and well-being scores as far as we capture it. Similar to what we were reporting for the whole sample, younger staff members also display slightly higher rates, as do ambulance personnel, nursing or healthcare assistants, and I will come back to that in a second. Financial concerns are also common among certain groups, and I'm not going to go into all of these numbers in a little bit of in detail, but you see, for instance, the financial concerns there in the table below for the different band groups that you have in terms of the income bands, and then the percentage concern. Of course, you see a direct income effect there, of course, in terms of the financial concern, and younger workers, for instance, would be on a lower pay scale typically than perhaps more senior colleagues. And similarly, across the age groups, you see in terms of the percentage concerned being around that 37% in the 18 to 30 group, going all the way to 11% in the 66 and over group. I keep in mind that some of those older age groups, of course, are lower in numbers in terms of the participation that we have, for instance, in the survey. What about toxic issues? So we know there's this range of these factors such as mental well-being and so on, and financial concerns and so on that are also relevant for the NHS context. But what about some toxic issues? And I'll explain to you what some of those toxic issues are. Well, bullying, of course, is something that we look at, but also violence in this particular issue. There's obviously something particular about the NHS context, and of course, as I always say, that I guess perhaps in the NHS you see both the best and the worst of humanity, but nonetheless, in terms of the experience of NHS staff, bullying is very much part of that experience, and 12% of NHS staff that we surveyed report being bullied at work at least sometimes. If you compare that to all other organizations in BHW, that proportion is about 6.5%. So the NHS would have double the amount of bullying compared to the average participants or participating organization in BHW. You see some of the numbers there as well in terms of the NHS, where the bullying resides. These are not mutually exclusive categories, so you could be bullied in a number of different categories, for instance. So you have bullied by patients, bullied by managers, bullied by colleagues, and prefer not to say, but there's bullying occurring. And then you see also the levels of violence there, which are about, I think, on average, about 4% of NHS staff participating in the survey said that they had been exposed to violence in at least the last year. So these are toxic issues that are broadly seen as to be unacceptable in the workplace, and of course, is an issue that NHS is struggling with quite a bit. Another question, I guess, that is important. Do you know which staff groups face particular challenges? And this is again going back to some of the challenge that Steve made in his earlier presentation. And I just have two categories here because, of course, there's too much data to present to you in a lot of detail. So I have BMI in this table, and I have mental well-being in this table. And then you look across the staff groups as we categorize them in the survey, and then you see in terms of which staff groups have some of the most significant challenges. So, for instance, amongst operational ambulance personnel in terms of the categories in the organizations that we surveyed, we had about, in this case, 68% of the participants being classified as being overweight or obese, and a similar number in terms of nursing or healthcare systems. And some of those numbers vary quite significantly across the piece. In terms of mental well-being, again, those two groups have challenges, and you can see the numbers for yourself, but about 24% of operational ambulance personnel is at risk in terms of poor mental well-being there, and about 22.2% nursing healthcare assistants. In the other category, you see the not at risk percentage. And for instance, if we look at medical and dental personnel, so these are mostly dentists and doctors, you see about 14.1% being at risk. So there's huge, quite significant differences, or at least statistically significant differences amongst the NHS population. And of course, in some ways, your workforce is also not uniform. You have different professions working alongside each other, different pay groups and so on. So understanding the risks by these groups is quite critical in terms of actually thinking about successful interventions. So then the question is, what can we see that the NHS is doing about health and well-being? So kind of almost what is the offer and what can we say about the offer here? And what we find is that the core offer in the NHS is largely similar, and NHS organizations are doing more in particular. So there's more being done, and I think that is a tribute to the organization, and also a wider set of initiatives that are taking place after the Borman review, but also within NHS Improvement, NHS England, and also at trust level. There's a lot of emphasis being placed on this agenda. And the majority of interventions is offered nearly to all staff. So basically, you see in the table below, you have quite significant, sort of universal coverage. So 86% of interventions are being sort of targeted at all staff, so universal coverage. But now keep in mind what I was saying only a slide ago, and that there are quite significant differences between these groups. So there's a question here about targeting and addressing things and making it relevant to a wider group of individuals in this organization. So coming back to the title of my slide deck is the tick box exercise, and I will spend probably the rest of the presentation actually thinking about this a little bit. So here you see a wide range of interventions on the left-hand side, for instance, and you basically see on the first column, you see the percentage of employees are aware of the interventions, percentage of employees indicating they've used the intervention, and the percentage of users indicating the intervention improved their health. For all of these different categories. And what you see quite clearly is that awareness tends to be relatively low across the NHS population, so your population, in terms of actually what is being offered. So there's a lack of awareness around the offer. And the percentage of employees who indicated that they've used the intervention is also very low. So the question is, how does your staff engage with the health and well-being offer? And as such, is this exercise of putting together these health and well-being offers, does it go beyond being a tick box exercise, something that you need to have in place? Is this also driving the change that Steve was talking about in the organization? Is this driving really full staff engagement as well? So just moving on to the next part, and I guess the final part of my presentation is, what do we know from other organizations in BHW? And I always find that the NHS says, well, we're a very particular context, and Steve burst that balloon slightly by saying, well, actually, you're not that different from Royal Mail, perhaps, in terms of the complexity of the situation. And guess what? What we find is that the NHS is typically not that different from other large employers that employ a wide range of different individuals, and also in some ways, the health of their employees reflects perhaps the health and well-being of the wider population or surrounding areas in which they operate as well. So if we look across the piece in Britain's Healthiest Workplace, and we look at the challenges around awareness, participation that I just highlighted for the NHS, we see that these are shared. And what we see is that in Britain's Healthiest Workplace, on average, 50% of employees have access to any of the selected interventions. Now you see that in the NHS, the targeting was broad. About 86% was targeted across, across all of the employees in your organization, or at least was a universal coverage. But even then, you might find that different sites in your NHS estate, or different, let's say, college hospitals, or different types of locations, they might have a very different experience of having access to this. Of those who have access, only 22% are aware of the offer. So the awareness levels are very low. So there is a wider range of engagement across the piece. And of those who are aware, less of a third participate in the interventions. And so now we're down to about 7 or 8% of the total workforce. So that's not too different from the NHS. And then the question is, who participates? Are these the worried well? Are these the people who are really at risk? Are you really getting through? Are you engaging with the health risks of your most at-risk groups, and so on? And I think typically the answer tends to be maybe, I don't know, perhaps, these type of discussions. So this is something important to consider, and of course it's important to say that you're not alone in this challenge. But what do we know about participation? You've been drumming on to us about participation is good, and awareness is good. Is participation good? And so here we've done some econometric modeling on the data, and we say across the whole of Britain's healthiest workplace, so these are hundreds of thousands of employees and so on. And for those who participate in an intervention or start participating in an intervention, any intervention, so any part of a health and well-being offer, we can say these three things. So employees who start engaging compared to those who never engage reduce their work impairment, so this is productivity loss, absenteeism plus presenteeism by 3.3 percentage points. People always engaging reduce their work impairment, so productivity loss, absenteeism plus presenteeism by 3.1 percentage points compared to those to never engage. This is a little bit lower, so there's a real uplift when people start engaging and employees start engaging. And finally, employees who participate improve on a wider set of outcomes, and some of those seem intuitively easier to understand than others. So mental health, perceptions of bullying, we can see that happening, because these are obviously an engagement exercise, but also on better reported cardiovascular health. These people also reporting better blood pressure and different other aspects. So it's interesting. There seems to be something going on when employees are engaging in these offers. Keep in mind, in this analysis, we cannot see whether these are intrinsically the worried well only or participating. So there's more work to be done in this analysis. So how do you drive participation? And we're coming nearly to the end of my talk here. Some of these seem to be motherhood and apple pie kind of lessons, but I think nonetheless they are important to think about. Active promotion of the offer is very important. So what's the point of having a health and well-being offer when you're not pushing it out there, when you're not branding it, when you're not doing health promotion around it? And I see many contexts in which that kind of promotion is not occurring. Allowing employees time during working hours to participate. Now this seems also very straightforward, but can you fit it in this very busy NHS context where some of your nurses are working 12-hour shifts? So how are you accommodating those sort of things in terms of actually participation in the health and well-being offer? External and internal reporting on human capital. By this I mean are these things being discussed at board level and being reported back to staff? Are they being reported externally? And believe it or not, those organizations, and I don't know what the causal direction is, that report on their human capital externally and internally also see 22% higher participation rates in their health and well-being interventions. So it could be that those organizations that have higher participation in their health and well-being interventions are more keen to report on it. I would argue that it's probably more a cultural aspect, and those organizations that are taking it seriously also are driving participation more than in those interventions, or have more engaged staff from that point of view. And then the point that Steve was making, I'm not going to go into a huge amount of detail here, but it's senior leadership, it's a role modeling, and also the line manager support. Are they driving this agenda as well? Or in fact, are some of those line managers perhaps the blockers, and are the barriers to actually some of the staff participating in all of this? So then my final list in terms of some of the takeaways that I will leave you with, and coming back, I guess, to the original sort of theme of this webinar, is understand your health risks. Do you really understand what the risks are that your workforce and employees are facing? Understand which groups are facing these risks as part of your workforce. Different locations, different types of staff. Is this the young? Are these nurses? Are these specific locations that we have within our NHS organization? Introduce an offer that is relevant to staff and specific groups. This seems to be obvious, but many offers tend to be developed as a tick box exercise top-down without engaging with staff and taking their bottom-up sort of aspects into account. Promote the offer. Don't just have the offer, but actually roll it out. Stand behind it. Many messages are important within the NHS context, clearly, but there's no point having the offer without actually making people aware of it clearly. Drive participation in the offer, and I've given you some tips that we can see in the data that really start making a difference. Obviously, monitor the outcomes of the offer. As I mentioned, my whole life has been, or my professional life has been around creating evidence base for interventions and so on. So I always say monitor, evaluate, more research required, of course. Continue to improve the offer. This is not a one sort of time affair. In a sense, is you have to keep the offer up to date. You have to keep changing it. You have to keep engaging with staff and so on, because otherwise these things die over time. And then the final point, and well, I always wholeheartedly agree with Steve anyway, but I will emphasize this again. All of this makes business sense. You will see the productivity loss numbers that I presented earlier. And in the end, if you start on this journey, or if you continue on this journey, or if you step up in this journey, the important aspect is here. It should pay for itself, and it will pay for itself for relatively little investment. So I'm quite happy to consider some questions, and I'll hand back to Louise, who's been monitoring everything.
Great. Thank you very much. Thank you both. Okay, so we have a couple of questions that have come in. Now where to start? So, presenteeism was discussed earlier in our discussions, but it's often quite difficult to capture and measure. Where would you recommend trust start?
Shall I go first?
You go first.
I'll go first, and you give us a real answer. I think the first thing to do is to actually expect it, and to realise that NHS staff don't exist in a bubble. They're drawn from the people, the population around, and we know that there's a rising number of long-term conditions. We know that there's a rising number of risk factors in the population. So the public health data will give you an idea of how many people you can expect in a working population of 10,000 to have, for example, diabetes or asthma or mental health problems. There's an awful lot of case study data out there that you can actually use as benchmark comparator, both in NHS organisation data, but also data that exists in the public arena. And Chris has shared with you Britain's Healthiest Workplace or Britain's Healthiest Company as being one very big source of that sort of data. And then the second thing is that you can actually introduce specific measurement tools. So surveys like Britain's Healthiest Workplace have been designed so that some of the questions are capturing information about sick persons. In Royal Mail, we asked about things like caring responsibilities, about coexisting conditions, those sorts of things. And then the last thing is and again, it's almost going back to the first point, but it's being aware that actually there's an awful lot of evidence-based review information that's already out there. So things like the Stevenson Pharma Review has already done an awful lot of work to identify the proportion of people with mental health that actually are not absent, but they're not thriving in work. So there's a lot of places that you can find this information if you just start looking.
Yeah, I think you're right, Steve. I mean, there's a number of tools out there that actually, allow you to measure presenteeism. I mean, there's a wide range of survey tools out there. There's a wider range of aspects, and I don't want to send all of our NHS colleagues on some sort of big data collection exercise, because of course collecting data is expensive. There's also a bit of survey fatigue in many NHS contexts and so on. But simple things, if you think about presenteeism, the top three things that actually drive presenteeism are mental health, sleep, and financial well-being, as we can see it in terms of our models. So basically, keeping sort of the pulse of your employees in terms of these areas already gives you a really good proxy indicator of what might be going on in terms of presenteeism and so on within the workplace. And also, in some ways, actually breaking it down as such also gives you some aspects that are easier to action and operationalize. If I were to come into your organization and say, what are the top three things that you are doing about presenteeism, I think that would be a more abstract discussion than what are you doing about mental health, or what are you doing about poor sleep, or what are you doing about financial well-being. These are easier to break down in some ways and to move forward. If you're interested in measuring presenteeism or capturing it, there are all kinds of different ways of doing it, and we have one particular way in Britain Southeast Workplace, but others are available, and more tools are available around that. But of course, as I mentioned, there are constituent components as well.
But I think also it's important to create trusted ways of actually collecting the information.
Oh, sure.
Because if people feel that by disclosing an issue, it's actually going to generate some sort of awful sequelae in terms of their future career or whatever, then they're not going to actually be honest in terms of actually portraying the information. So part of a good health and wellbeing programme is creating a culture in which people trust enough to be able to actually express needs.
Great, fantastic. Thank you both. Another question that's come in regards to external and internal reporting on human capital, what are the metrics typically included in this?
So there are things like attraction measures, which are about how easy it is to recruit people and how many applications you get, those sort of things that actually can be used. There are attrition measures, so those are things like turnover, absence, those sort of things. There are understanding the costs that are actually associated with onboarding, training, the cost of losing somebody from the organisation. So actually in Royal Mail, a postman that was earning £18,000, it would cost £54,000 to replace them. So it's having that sort of numerical data at your fingertips, which is quite important. I don't know if you want to come in there.
Yeah, I think there, I think there's a wide variety. I think there are certain organisations that also report on specific health conditions, the less controversial is, for instance, smoking rate. That's a traditional one, but also on sort of mental health aspects, if those things are being measured within the organisation. A lot of organizations are starting to focus on staff engagement, so like looking at engagement aspects, and which again they have engagement surveys and so on, reporting back on that, which is a sort of another outcome measures. So I would say there's broadly three aspects that organizations report on. One is around health outcomes, the category that I already mentioned. So it could be chronic conditions, prevalence of MSK in the organization, and different types of mental health perhaps. There are the organizational aspects that Steve mentioned, among others, retention, absenteeism, and so on. And then staff engagement, sort of kind of softer measures, something that tells you something about the culture of the organization. The last one is particularly, for instance, in vogue in the financial sector. They see a strong link between staff engagement and, for instance, compliance, which is also relevant to the NHS in some ways. So they saw that, for instance, rogue traders or traders in particular had very low engagement with the organization and so on, and they also showed most in terms of lack of compliance. That's where the fines were coming from, and so on, and so that became a real increasing problem for them. And of course, you have somewhat parallels in the NHS between those sort of things.
Great, thank you. And I guess building on that point, when writing business cases for investment in health and wellbeing interventions, how do you demonstrate that causal link?
So sometimes you don't need to demonstrate a causal link, and I actually feel that sometimes it's not being able to identify individual elements, but the impact of the whole thing that actually is important in terms of driving a case. There's a lot of case study evidence out there. There's a lot of published and peer-reviewed information, not just from outside the NHS. So an excellent study done in Southampton that actually looked at simply having a good case management plan around each person that had been off sick for more than 3 weeks, and showing the return on investment that was generated in that programme. So there's lots of information that you can draw down and look for in terms of case study information, but this has been piloted, it's been done before, and this is the impact that actually it has created. Now, the actual level at which that cause and effect happens may be different in different programmes. But from my perspective, and a lot of those case studies are actually reflected in the actual staff health and wellbeing framework.
Yeah, I mean, I've been working in research for most of my life, and I'm still looking for the holy holy grail of causation, in the sense that I think, for me, some of the business cases that have been, and I think Steve is right, I think in terms of the existing work around, certainly the link between health and well-being and outcomes in the NHS, the case studies that we have, I think the evidence base is very strong on these very clear associations between better staff health and well-being and a wider range of outcomes. I think in terms of driving the business case and presenting the business case internally, I think there is, I think Steve mentioned the return on investment, particular interventions and programs, and that is something to where you can look at. If you have specific interventions in place, trying to monitor that, how much are we spending on them, what is happening in terms of the groups that are participating. And I guess the gold standard there, and that happens very rarely in terms of workplace offers, is, for instance, a randomized control trial or some sort of experimental approach and so on to actually establish that. But you don't have to go that far. There are more simple metrics available.
I've always said there's never been a randomized control trial of parachutes.
Yeah.
And sometimes you just don't need to.
Well,
you understand it works.
Absolutely. And but also I think in terms of driving at the macro level, and I think some of these big metrics, there might be other things going on within the organization. You might be affecting through the health and well-being program wider cultural issues that are happening in the work environment, and that then drives a range of outcomes, such as, for instance, some of the outcomes that Steve presented, I think, from the trust in Bristol, and that starts building that case in terms of that these kind of I guess using Steve's metaphor and so on, we don't need a randomized control trial on parachutes. I mean, in the sense that starts moving the debate, and it makes it common sense. I always, just to come back to it, I always say that if you have an IT problem, your computer doesn't work, and I hope we don't have one right now in terms of this webinar, but if you have an IT problem and the person responsible for IT would come back to the board and says, we think we're addressing 7% of the issue and so on, that probably wouldn't be acceptable. And in some ways, what we see in terms of in terms of some of these health and well-being offers, when 7% of staff are participating, maybe not the at-risk groups and so on. I'm not saying that you need to engage every single member of staff and cover all the risk groups. But in certain aspects, to me, it feels like complete common sense that you sort of step into that space.
We fixed the laptops that were working anyway.
Yeah, and you might be spending, I don't know, 15-20% of your budget on IT and so on, and the rest of it on staff and so on, and not having that kind of approach. I mean, it seems to me, completely common sense.
Great, thank you. What are your tips for reaching hard-to-reach groups when taking out your health and well-being offer?
I think the first thing is understanding that some groups will readily engage much more easily, and some groups are harder. I spent a lot of my career working, and I know it's a very different demographic to the NHS, but working with men. And men, for example, are less likely to engage with some of these health and well-being type initiatives, just simply because of the style in which they react to it. So the first is actually understanding the demographics of your organisation, and understanding, I think Chris already said earlier on, understanding which groups have got issues and which groups haven't. The next thing is actually talking about in their language. So actually, again, going back to men speak about health issues in a different way. It's understanding that actually your estate staff may feel differently to your nursing staff in terms of their existing awareness, and what is the priority and what's important to them. And so the offer to them needs to be phrased with an understanding, or actually either an understanding or a need or a desire to explore what the need is in the first place. The next thing is to provide mechanisms so that they're actually part of the debate and the discussion. Health and wellbeing programs shouldn't be done to people; they should be done with people. So, brilliant example of that is the Schwartz rounds, where it's not just the doctors and the nurses or whatever that actually participate in those meetings. It's actually everybody that's got a part of the jigsaw that can actually help explore the problem. So I guess those would be my top tips.
Yeah, and I think you're right, Steve. I would probably also maybe think about some of the structural impediments as well, why people cannot
barriers.
The practical barriers and so on, and sort of think those through. Like some places that I've been within the NHS estate, some of the health wellbeing interventions were offered about 1.5 miles away from where clinical work took place or where clinics were being done, and nobody in the NHS is going to walk for 1.5 miles with their very scarce time to get somewhere and then walk all the way back and so on. So bringing it closer perhaps to the to your staff, I think is quite important as well, and making it available. So for instance, I've heard some really interesting example of health screening taking place next to operating theaters because operating staff didn't have the time to actually engage with it, so they brought the interventions to the staff.
Or at lunchtime when you're on a night shift.
But don't offer it after hours for somebody who's just worked for 12 hours because they will want to go home, sleep, see their kids, do other things. Completely understandable, you know.
Great. Thank you both. And just on that final point, actually, also, I think the framework and the diagnostics, the NHS Health and Wellbeing framework, can be quite a helpful engagement tool in that.
Absolutely.
As you were saying, asking for solutions from people. So just my little topic as well there. Thank you both very much for a really interesting and engaging webinar this afternoon. Really very much appreciate that. And thank you to everybody for sending through your questions. That's been really helpful. Hope you found that engaging, and we'll be making the webinar available shortly. Once we've put subtitles on it and things like that, we'll have it on our website and circulate that. And for those of you registered today, you'll be able to access it on the link in the next 48 hours. So without further ado, thank you very much, everybody.
Thank you.
And until the next time.